then yes, sir. Nana me then the answer, yes, sir. Respect is reciprocal, even though una know say I special. Anybody, when no one to surgery. Anybody, when not the carry body. Na can something, na can something. To bata fele fele, na can something.
Hi, everyone. I think we'll get started. Thank you all so much for joining us today. We're really excited to have you all here and to be sharing all of this work today. So, as you all know, we're here to explore both a health education campaign for communities as well as a dialogue guide for healthcare providers that support hepatitis B vaccination uptake in newcomer communities. So first, you'll hear a little bit about the Migration Health Initiative, followed by an overview of hepatitis B in newcomer communities. Then we'll walk you through the Protect Your Family Health Education campaign, as well as the dialogue guide for providers. And at the end, we'll leave a little bit of time for the Q&A. Just a couple of reminders, this webinar is being recorded, and you will get the recording, the slides, and links by email in a couple of days. Please feel free to also add any questions that you have in the chat or by using the Q&A feature, and we'll be monitoring the chat and the Q&A throughout the course of the presentation. I will be one of your speakers today. My name is Riddhi. I'm an independent researcher. I'm joined by my colleagues Sarita Wilkins from the Migration Health Initiative, as well as Diana Haj Ahmed from IDEO.org. And with that, I'll pass it over to Sarita.
Thanks so much, Riddhi. I'm just going to give a brief overview of MHI before we get started. So the Migration Health Initiative exists to support the health of people experiencing migration through partnerships, collaboration, and community-driven solutions. You may have heard of us from our old name, which was the National Resource Center for Refugees, Immigrants, and Migrants, or NRC-RIM. And we were initially funded by the CDC in 2020 as part of the COVID-19 response. But since then, we've evolved to respond to a number of health conditions, everything from infectious disease to mental health and nutrition. And all of this is in support of people experiencing migration. And in 2024, we became a program at the Task Force for Global Health. And at MHI, we imagine a future where migrants are not just the beneficiaries of public health initiatives, but are involved in the design and implementations of the solutions that affect their communities. So with that, we specialize in taking the innovative ideas proposed by communities and turning them into capacity building resources for organizations around the world to use. Collaboration and partnerships are central to our approach. So rather than working directly in communities, MHI focuses on influencing the systems that serve them. So that includes community-based organizations, governmental health agencies, health systems, and intergovernmental organization. We have several areas of work, including pilot projects and toolkits, health education and communications, workforce development, qualitative interviews, and technical assistance. But we would not be successful without the contributions of our partners, including International Rescue Committee, Migrant Clinicians Network, Afghan Health Initiative, and others. And in addition to those listed on these slides, we've also worked closely with the UN Migration Agency. Before getting into the campaign, I wanted to offer a little bit of context about why we are focusing on hepatitis B. So hepatitis B is an infection of the liver and has no cure. A lot of people get it as children and could have it for the rest of their lives. And it's the leading cause of liver disease and liver cancer worldwide. It's usually asymptomatic until the liver damage becomes pretty severe. Now, hepatitis B is common in many areas of the world, including several countries in Africa and Asia. So that's going to be our focus today. There's also people who might be at higher risk, like babies or children who have a parent with hepatitis B, healthcare workers, or people who've been to jail or prison. This map shows the prevalence of chronic hepatitis B by country, with blue and green indicating low prevalence and orange or red indicating a higher prevalence. So you can see here that the countries that are most affected by hepatitis B are in sub-Saharan Africa and Eastern and Southeast Asia. The countries shaded in red have a prevalence of between 8 and 13%, and the global average is about 4%. So you can see that's quite a bit of a difference. Some newcomers may have higher rates of certain infectious diseases like hepatitis B compared to folks in their destination countries. And so, many newcomers might come from places where hepatitis B is very common, or they may also experience disruptions in their healthcare access before or after they arrived. And then with regard to forcibly displaced communities specifically, those being refugees and asylees, they might experience other situations related to their migration journeys, like congregate living facilities or experience with violence that can cause hepatitis B to spread more easily. Now, until recently, the vaccine for hepatitis B was only recommended for people in certain high-risk groups, like people experiencing homelessness or people who use intravenous drugs. But in 2022, the CDC updated its guidelines to include universal screening and vaccination with those additional measures recommended for the high-risk groups. And there are other organizations. We have friends at the Hepatitis B Foundation and CDC who have really great health education resources for newcomer communities, but we could see areas where we could fill a gap by adding value, improving the language diversity that's offered, adding new formats, making resources customizable, and then pairing those with resources for providers. So to respond to these new CDC guidelines and the disparities that we see in newcomer communities, we've created a toolkit that we're calling the Hepatitis B Dialogue Guide, which is for healthcare providers, as well as Protect Your Family, which is a mass education campaign. So I'll pass it over to Riddhi to explain how we developed the campaign. Thank you.
Thanks so much, Sarita. So I'll give you an overview of the campaign using the methods that we use to develop the campaign using a community-informed approach. So the campaign itself had a few goals, and were all centered around promoting the adult dose hepatitis B vaccines. And for this work, we used a community-informed approach, which prioritizes collaboration with communities being served to ensure relevance, cultural sensitivity, and effectiveness. And we worked with community leaders who shared their feedback across different aspects of the campaign, and our team synthesized those learnings to develop a culturally resonant campaign. For this process, we recruited 9 immigrant community leaders representing 10 countries and 11 languages across sub-Saharan Africa and Asia. We conducted one initial 60-minute in-depth interview with each community leader and developed, sort of to develop that rapport and understand barriers and facilitators around hepatitis B specific to their communities. This was followed by 3 90-minute focus group discussions with the entire cohort of 9 people, all over Zoom. And community leaders spent a total of 6 hours with our team over the course of 4 weeks and were fairly compensated with a stipend for their time. Through the activities, we explored leaders' awareness of hepatitis B, barriers around awareness and access, and the expectations and priorities that these leaders had for the project. And during these focus group discussions, we explored various tones, language choices, channels, layouts, and imagery through the course of those 3 focus group discussions. And then we also offline had simple activities for the leaders to sort of test translation of some of the key phrases that we would be using as part of the campaign in the 11 languages across the group. And with that, I'll pass it to Sarita to explain some of the features of the campaign.
Thanks so much, Riddhi. So first I want to talk about the messaging. We found that overly fear-based messaging deterred interest in action. So community leaders told us it would be better to approach our messaging from a more actionable and hopeful framing. So in this example on the left, the messaging around destroying your liver, death, risking your health. That's not as compelling as the example on the right, which plainly explains why it's important to get vaccinated even if you're healthy. We also know that people want some detail about hepatitis B to inform their decision making, and this is more important than emotional appeals. So an example on the screen on the left, you see terms like stigma or isolating, which really alienated community leaders because it reinforce their fears around hepatitis B. So an example on the right, that explains the benefits of seeking treatment for hepatitis B, which is much more resonant. We also found that people wanted very specific, actionable, and direct messaging. So the example on the left says hepatitis B silently impacts communities, but it doesn't really say how or why. The example on the right is simple and direct. It informs people that hepatitis B is preventable and how, all with a single short sentence. So, in contrast to messaging that we found to be very common with COVID-19, our community leaders did not find community protection to be as compelling. They told us that speaking to individuals and their interest in protecting their families or inner circles was much more appropriate for this kind of campaign, and you can see that reflected here on the right side of the screen. Finally, focusing on the permanency of the condition, so irreversible liver damage, that was more resonant than focusing on the risk of death. We found that focusing on that permanency, that can go two ways. So on the one hand, a person can have hepatitis B for their entire lives, but on the other hand, the vaccine will offer lifelong protection. Now, in terms of color and format, people preferred our blue-teal branding over styles that were more obviously culturally specific. They quickly rejected a version of this fact sheet that used Pan-African colors, and they preferred a more neutral version that you see here on the right. And leaders wanted to see themselves reflected in the image, but they didn't want to see exclusively their communities in the image. So they told us that it would be that putting just one community would get people to believe their communities were responsible for the spread of hepatitis B, or that it was somehow their fault, but they advocated instead for really diverse representation with people with different races and ethnicities. They also wanted to see pictures of people they could relate to. So they loved this soccer image, and they were generally less interested in these kinds of faceless illustrations. And having photos like this rather than images is definitely more challenging for us because it takes a long time to source those stock images that are reflective of the cultures that we want to represent. But we felt that the investment was worth it to create a more resonant campaign. Community leaders wanted to see photos that were suggestive of medical procedures but didn't actually show blood or needles. So if you see on the left, the photo is of a person who just received their hepatitis B vaccine. That's preferred over showing the vaccination itself. And on the right, showing someone preparing for a blood draw was preferred over showing the blood itself. We also tested an infographic style fact sheet, and the community leaders liked the icons that we used, but they just felt it was too much information. It was too overwhelming to look at. And so they advocated for a simple layout that included just a couple icons to illustrate the point. And with large photos, they told us that was definitely the way to go. And then our materials for this campaign are rigorously translated in 16 languages. And we looked at a number of different factors when deciding what languages to translate into, from immigration patterns to hepatitis B vaccine uptake in home countries. We also looked at the availability of materials from other organizations to identify those gaps that we might be able to fill. For example, people from Vietnam are disproportionately affected by hepatitis B, but there's already a lot of health education resources available to serve them. And the languages here that you see in bold, Dari, Oromo, Pashto, Rohingya, and Tigrinya, we didn't find any materials in these languages in the places that we looked. So we wanted to be sure that we captured these. And we know that health education materials are most effective in the hands of trusted messengers. And so we wanted anyone to be able to customize them without the need for design software or any special expertise. So we created the materials themselves as, PDFs or images you could download, but we also have templates in Google Slides and Canva that also include photo banks. And so anyone can remove our logo, add their own. They could swap out the photos to better reflect their communities if they so choose. And then community leaders also told us that if we want to reach people across generations, we needed to invest in multiple formats. So Our materials are available in print, digital, and audio-visual formats to meet this need. So those are just a few highlights. We know how important it is um, to have health education materials available for communities, but we also want to be able to support providers and their counseling. So with that, we created a toolkit with them in mind, and I'll pass it over to Deanna to explain more.
Thank you, Sarita. As Sarita said, I'll be sharing the Hepatitis B dialogue guide that was developed by IDO.org alongside MHI and as part of this effort. So our project brief here was how might we equip healthcare providers with key assets that support them in counseling adult immigrant and migrants from sub-Saharan Africa and Asian communities to get screened and vaccinated for hepatitis B in a way that's culturally sensitive, dignified, and effective. And in order to do that, we've engaged the healthcare providers and communities that will most likely use it. We talked to 11 providers ranging from nurses to primary care providers and infectious disease physicians across the US and Canada that work in public health departments, refugee clinics, hospitals, and community-based primary care. We've also worked closely with 2 community health workers from the Refugee Women's Network that are representative of sub-Saharan African and Asian communities and have deep trust and knowledge established with their communities. With their help, we were able to recruit community members that we've talked to and tested with in order to understand what are their most pressing needs and pain points encountered with healthcare providers during their checkups. Gauge how much they know about hepatitis B, and get their feedback and input on possible toolkits that would be used with them. Through this process, we were able to understand what's resonating, what's not, and what are cultural nuances that need to be integrated into a toolkit. We've also talked to 3 experts that have deep understanding of hepatitis B and have worked with refugee, immigrant, and migrant communities. With these folks, we've used different research methods to engage them. These range from one-on-one interviews to sacrificial concepts, ranking barriers, and building a toolkit together. In the one-on-one interviews, we wanted to understand the needs of the healthcare providers, how they introduce preventative care, how do they interpret refugee, immigrant, and migrant community attitudes towards hepatitis B and vaccination, and what do they need and from a tool to fit in their routines and within the time allotted for counseling. We've also showed the providers and the community sacrificial concepts that allowed us to imagine what the toolkit could be. Is it a chatbot? Is it an awareness campaign for providers with a hepatitis B champion? Or is it a story booth in the waiting area of the clinic? The concept sat on different points of the spectrum of care, from intake to follow-up, and allowed us to understand which point needed the most support and address the biggest needs. We also ranked barriers standing in the way of testing and vaccination with both the providers and the community, whether it was time, transportation, language, existing beliefs and misconceptions, or any others that came up. Finally, we've worked together to build what a potential toolkit would include in terms of content and what formats are most accessible, resonant, and easy to use for both the providers and the community. We've surfaced many different learnings in this research, but the one that actually guided us towards where we landed today with the toolkit was this specific one. Silence can signal politeness, not understanding. In many refugee, immigrant, and migrant communities, patients can appear compliant. They may stay quiet. They might quickly agree to screen or vaccinate, but this silence often masks fear, confusion, or a sense of obligation that's rooted in cultural deference to authority figures. Providers may mistake this lack of resistance as agreement. The patient was passively agreeing without a full understanding of the recommendation. And the issue at hand here is that made follow-through less likely, especially that hepatitis B vaccine is more than one dose, and we needed the patients to come back to complete their full vaccination in order to be immune and fully protected. So we wanted to ensure that the patients are fully brought in and have buy-in towards getting vaccinated and screening so that we can shift from quiet compliance to meaningful care. And that meant that providers needed built-in proactive moments to invite questions and check for real understanding as part of their routine. And so the opportunity that we embarked on within this scope of work is how might we enable providers to proactively create the conditions to equip patients with the information they need to make decisions about hepatitis B screening and vaccination, while also integrating a higher level of the cultural nuances that providers should be aware of and consider during hepatitis B counseling. We also wanted to ensure that the framing of the mass campaign, communications campaign that Sarita just shared continues to present hepatitis B vaccination as an act of care and not just a medical routine. So what's inside this toolkit or guide? This toolkit is made out of 5 parts, starting the conversation, which is all about building trust in a culturally attuned way using essential principles and strategies. Establishing the facts, and that's all about addressing misconceptions and building knowledge through simple visual cards. Exploring mindsets, which is all about understanding how to address mindsets and beliefs that are prevalent amongst these communities and be able to address them strategically. And then finally, we wanted to ensure that the providers are armed with a way to plan next steps with the patient. These elements are all modular. Providers can take any part of this kit and utilize them in their hepatitis B counseling. It's not meant to be used from 1 to 4 in sequence. For example, some providers are very well equipped in starting the conversation and building trust and may need support in motivational interviewing tactics, and others may be the opposite. So this allowed providers to pick and choose based on their needs. So let's dive into each one of these sections, starting with starting the conversation. You'll see essential principles in there. These are fundamentals that many providers have learned in medical school, but we were repeatedly told that it's good to have them there as a refresher. For example, this principle is about starting with emotional safety, not medical facts. Each principle provides things to say as a script. It offers things to try and things to avoid as well. Then we have the cultural cards. There are many, but here are 2 that you're seeing, one on stigma and fear of disclosure, and the other on family dynamics and patient voice. Each cultural card has tips for providers. Those sometimes are script of what to say, and other times they offer advice of what to be aware of and do during the interaction. The second part is establishing hepatitis B facts. These are double-sided cards that are available as templates on Canva, where they can be downloaded and printed. One side is facing the patient with the visuals, and the other side is meant to be for the provider. The provider can show more than one card and ask the patient which visual they'd like to learn about, then read out what's on the back with the support of the interpreter. This process is meant to be interactive and proactive. It allows the provider to show and give the patient the ability to choose what they'd like to learn about. And what we've noticed was that allowed follow-up questions from the patients when we tested it. And each one of these facts was chosen based on the misconceptions and myths that we've heard from the community and the CHWs. And they utilize short and simple, plain language with no medical jargon. And the deck of the cards is available with visual representations of both African and Asian communities. Then we have the Exploring the Mindsets section, which comes with a poster that has 6 mindsets. The provider can ask the patient which one of these 6 mindsets is most representative of them. Here we have number 2, which is, I'm not at risk for hepatitis B. And in the guide, the healthcare provider has information on what this mindset might signal and it offers a strategy for the provider to address it, build trust, clarify what's at stake, hear the whys of the patients, and then plan on how to move forward. All of this is rooted in motivational interviewing practices and frameworks. And the poster use is optional, as we heard that the providers can form an understanding of the patient's mindsets while listening and in conversation, and they just like to reference the guide for support. And finally, planning next steps. At the end of a counseling session, the patient may be at different points of readiness, whether the patient wants to think more about getting vaccinated or screened, or if they're ready but need support in planning out the doses and scheduling them. There are steps for the provider to follow and resources to offer from the communications campaign. This entire dialogue, along with the Canva templates, is available on MHI's website, and Sarita will provide us with a walkthrough of that, so I'll pass it off to her.
Thanks so much, Deanna. Riddhi, I am going to seal your screen share for just 1 second. Okay. So I am going to show you the hepatitis B campaign first and how you can customize it. So there's just a little overview about the campaign, and something I want to mention is that we have printing mini grants available. So if the time and cost of printing is a barrier to your organization and using these resources, we can definitely arrange for that for you. So there's going to be a link here, and my colleague Erin will share it in the chat as well. But I wanted to point out we also have, this is the US version of the materials. It includes information that's really specific to the US context, like vaccine, like the insurance of how it will cover the vaccine, or eligibility and things like that aren't necessarily relevant abroad. So you can click this button to be referred to the international version. So these are all the different sections. You can click on these to jump. So we'll look at our posters first. We have one poster on testing and one on vaccination, and then you can either download these as a PDF, customize them in Canva, or customize them in Google Slides. And I'll just look at the vaccine one first as an example. So this is an 11 by 17 poster. You can print it on a regular office printer, but it also includes a QR code here at the bottom. And that QR code will link to a video that has the same information that the poster has. And all of our print resources have something like this. So these are our posters. We have fact sheets, and then I'll just show you how I might customize this. Let's look at the French one, actually. Click this Use Template button. I'm going to use the Google Slides version to demonstrate how to customize. And so you can see this is a QR code that links to a video that talks about vaccination. There's similar information that's on the fact sheet. But if you have your own QR code you want to link to your website, I've heard of some places wanting one where you can make an appointment or fill out a contact form. That's totally fine. You can take this off if you want to. If you don't want to use our logo, you could take that off as well, or you can add your logo next to ours if you wanted to do that. And then this is the second page. It's similar. It has the QR code and the logo. But then you have these pictures, and I'll just zoom in here and show you. We have one of somebody getting a vaccination, one of a baby, and one of a pregnant person. So maybe I don't like this baby photo. I'd rather have a picture of babies that are shown in a family. And so I have these photo banks here. Here's my baby pictures. And I say, well, I like this picture of a baby with its mother. So I'm just going to copy that and paste it in here. I did Control C and Control V, and then it's sized perfectly. So you don't have to worry about stretching it out or having it be blurry or anything like that. And then you just click File, Download, and then PDF, and that will get you your fact sheet that you can use for folks. So I'll show you that the fact sheets, we have social media assets. There's about 40 of these. that you can post kind of as carousel images like on Instagram or send on WhatsApp. We have a conversation guide here that's meant for bilingual community leaders to talk to others about hepatitis B screening and vaccination. And it's written in a way, it's not like regular frequently asked questions because it reflects the priorities and the perspectives that the community leaders told me about when we were working with them. We have text message templates. So if you want to send this on WhatsApp, there's a series of sentences here that you could send, and you can see that they're numbered because if you want to send, for example, you think number 11 looks good, well, in Dari, you can go to number 11 here, and you know that that's going to be an equivalent translation to the English version. So everything's numbered. We have audio PSAs for 2 for testing, 2 for vaccination, and 1 for treatment, and they're at different lengths. The short ones are about 1 minute long, and the detailed ones are 2 to 3 minutes long. And you'll notice here that the audio video is the only areas where we have Rohingya, because we know that language has a really rich oral tradition, and we want to respect that by offering resources in a format that works best for them. So there's a script here. If you want to have a trusted messenger, a religious leader, or someone else record this PSA instead of using our recording, you can do that with the pre-translated scripts. And then we also have video PSAs. So these are all on YouTube, and you can click these for the short version or the detailed version of each of these topics. So for screening, vaccination, and treatment. For the toolkit, I'll go through this quickly. And so you can see here we're in the overview section and we'll work our way across, but this does have downloads. If you just want to download a PDF, put it in like a binder that you keep at your desk or having it available to other clinic staff, you can certainly do that and just download them here, or you can walk through the web version of the toolkit. So as we're looking at starting the conversation, you have some key principles here, and as you click on them, so start with emotional safety. You click on that, it gives you ideas for things to say, things you might try, and things to avoid. And so, this example, things to try, using we or you and your family instead of just you. But avoid, for framing the decision in ways that imply blame. So that's just an example of that. And then we have cultural adaptations. So when you're talking about stigma or fear of disclosure, we have a description here and then some tips about kind of what should you do with that information that's available here online. So for establishing the facts, you heard Deanna talk about the cards that were two-sided, where the patient might see the illustrations and the provider sees the descriptions. And so we actually have those here. There's a version for Asian families and a version for African families. And as you hover over these, it will give you the facts. And so if you wanted to download them as a PDF and cut them out, have them at your clinic, you can. There's a download button here. Or if you have an iPad or something on site, you could do it online with these cards. In the Exploring Mindsets section, you can see, examples of things you might hear a patient say, and then what that means, and then how you might respond using the 4 steps: engage, focus, evoke, and the moving forward together. So that is going to be here. I'm not at risk for hepatitis B. You have a whole section on that. And then finally, planning next steps. So for planning the next steps, there's different situations. If the patient wants to think more about getting screened and vaccinated, what's some things you might say or do? Or if the patient wants to get vaccinated but doesn't want to do the blood test, how might you respond to that? And so this has just a number of different options, as well as just some of our citations and that sort of thing. So I'm going to stop my share, and we do have time for questions. I'm just going to launch a quick poll to kick us off, but definitely put your questions in the chat or by using the Q&A feature.
Great. Thanks so much, Sarita. Well, while you all are maybe filling out that poll, I'll start with a couple of questions for both of you. And maybe a question actually first, maybe for Deanna. For example, if clinics don't have as many resources but would still be interested in using the guide, do you have any suggestions about how someone could start small with the guide or maybe use a portion of the guide?
Yeah, absolutely. I think we've seen and heard providers talk about wanting to utilize maybe the establishing the facts section, especially when things are coming up during the counseling and being able to utilize that section. And as you saw, Sarita shared, it can be digital as well if you don't have the resources to print it out, whether on an iPad or on a screen. So that's definitely a part that can be utilized easily, as well as the mindsets and what they're hearing in the clinic, and being able to have maybe a page printed or bookmarked on your computer or iPad to be able to access how you might address these mindsets as you're hearing them. And if I remember correctly, one of the providers doing research said that the scripts of what to say are very helpful because it can be easily memorized and just used during the visit if something comes up. So I think these three bits in the guide are helpful and very easy to use for clinics that have limited resources.
Awesome. Thanks so much, Diana. And Sarita, a question for you. For folks that are working with the Rohingya community, obviously Rohingya is one of the languages. Do you have any advice for members who are reaching this community with the mass campaign?
Yeah, that's an excellent question. We heard from several of our partners that Rohingya languages was a huge need for the campaign. And, when we talked to folks from the community, we did, I mean, kind of knew this before, but it was helpful to talk to folks from the community who really reiterated for us that Rohingya is very much an oral-based language, and people much prefer to communicate. Orally. And so that's why for our campaign, we only have audio and video resources. And even, one thing that we had, as I showed you, we had the scripts included for the audio PSAs in case a community leader wanted to perhaps re-record it in their familiar voice. And I definitely recommend doing that. What I don't recommend is using that script by itself, because a lot of people, they might see it or not recognize it, since Rohingya can be written in a lot of different scripts. They might not recognize it, and really just focusing on putting the audio and then the video resources in front of people is what I would recommend for sure.
Great. I think that makes a lot of sense. I have a question for both of you. I'm curious if you have advice, for another organization doing similar work, whether it's developing a mass campaign or developing a provider toolkit, if you have advice on how your approach, how they might approach that type of work.
I can start, and then I'll hand it over to Deanna. And so I guess in working with a mass campaign or something like a toolkit or a conversation guide, I think it's really important to start with what the community what they think is important, and um, instead of kind of going in with your own agenda, because we know that there's a need for hepatitis B, for example, but then you know one thing that surprised me is that people didn't want culturally specific branding, that they didn't want the Pan-African colors for a campaign that was for African immigrants, that they wanted to have that more neutral color palette. And so, just getting that advice from community leaders and trusting them and their expertise is going to go a really long way in making your campaign more effective. If I had just gone forward with the Pan-African colors in the campaign, it wouldn't have been as successful. It might not get as much uptake. People might not even look at it. But and sitting and really listening to community leaders and showing them options really, I think, sets this campaign apart from some others that you might see out there. Deanna?
Yes, plus one to everything Sarita said. I think one thing I would add that was really helpful in our case was partnering with the Refugee Women's Network. So finding partnerships within the community that truly understand the community and the community needs and speak the language really allowed us to further understand what is needed, because they have been spending a lot of time within their communities and know what are these needs and pain points. And if you are creating something that is provider facing, it is still important, obviously, to engage with the providers and see where are the similarities and differences between them and the community, and where you can find the spots that you can support both of them at the same time. Because ultimately, if it's community resonant, but then it's not working with it within the provider's time, for example, then it won't be used. And if it's just working within the provider's time and style and routine, then it won't work for the community. So both audiences in this case need to be listened to, and create a space for both of them, because it is used at a moment of interaction versus in silo. So that's what I would add, but definitely +1 to deep listening and starting with the community.
Yeah, I want to reflect on something you said, Deanna, because it's the whole striking a balance between what the community needs and what providers might need is also kind of what we tried to do with the campaign, because obviously the campaign is reflective of community perspectives or the advice that our community leaders gave us, but we also needed to make it a way that's going to work for health departments or that's going to work for CBOs, and that's why we let people remove our logo, for example. That's why the posters are on 11 by 17, because not everyone has the budget to go to a professional printer and get something printed really huge. So being able to really focus on both needs is going to be important, whether it's a toolkit or a campaign.
I love that. Yeah, I think that's great. I love those specific examples that you shared. I'm curious, kind of a follow-up question. I'm curious, if there were times where members of the community cohort, whether it was for the mass campaign, the cohort sort of disagreed about something and how that sort of was reflected in, some considerations for the final design. But also, Deanna, if there were disagreements that you saw between what, community health workers wanted and what providers wanted, and, how you sort of resolved that in developing the final design for the provider toolkit.
I can start with an example that just came to me. I think, in when we were testing the toolkit, there were 2 versions of it, and the establishing the facts cards weren't actually part of the dialogue guide. And the reason for that was that the community members really wanted to learn about hepatitis B in general, how it spreads, how it might be prevented, and they needed the knowledge and awareness. But we obviously also didn't want to replicate the communications campaign, and the providers needed more strategies around motivational interviewing or cultural nuances. And so we're able to bring these 2 together and also articulate to the providers why it was important for us to include the establishing the facts cards as part of their routine. So I think, although there was not disagreement, but different perspectives of what's most needed, also communicating with the other audience why we're including it is important, because once we told the providers why, actually, okay, that makes sense, and we definitely want folks to understand hepatitis B during the moment and have follow-on questions so they have buy-in. So I think that was a moment where it's not full disagreement, but we've seen some, preferences.
Yeah, I would say similar, not so much disagreement, but some preferences with the campaign as well. And I thought of one example, and I remember we're trying to decide if we should have photography, like stock photos, or if we should have illustrations. And the value in having illustrations is that you can create any cultural marker you want. You can have women wear hijab, or you can have people with different hair textures, and you can kind of just create that. But for some people, that's difficult to connect with. And so we generally had consensus that people liked to have photography. But I remember one person had said, I like the photography, but I can tell that that person in that photo is African American and not African immigrant. And so, of course, right? But then, so what I ended up doing is like I could have gone back and just done illustrations and had them, look exactly the way I wanted to. But what I ended up doing instead is sourcing stock photos from photographers that were based in sub-Saharan Africa. And so going to their, I use pexels.com, that's a stock photo site. Also, nappy.co is another good one for diverse stock photos, but you can sometimes see where the photographers are based, and that's kind of how I addressed that comment from the community leader.
I think that's great. Yeah, incredibly helpful. Also, I didn't know that you were getting stock photography from folks that were actually based in Sub-Saharan Africa. That's really cool. Um, Victor has a question in, oh, well, I think it sounds like Aaron's answering that question in the chat, so we can move on to a different question. Um, Great. Let's see.
I actually want to respond to that question a little bit. So Victor had asked, with recent budget cuts to public health, how is that affecting our vaccine promotion? And Aaron very helpfully responded that, the funding for this project was not reduced. We're just wrapping up a little bit early, and that's true, of course. But one thing we tried to do with this campaign and with all of our campaigns is how can we create a resource to save other people money if their budgets are cut? So we don't want like a health department or a community-based organization, for example, to spend a lot of money on, translations, which can be really expensive, or hiring a graphic designer to create stuff like this. And so that's part of why we exist, to really build the capacity of other organizations to serve immigrant communities better. And that's part of what we had in mind with this and the customizable formats and that sort of thing. It can really help organizations that do have a reduced capacity and make their limited resources stretch further.
Thanks, Rita. This one's maybe a little bit more of a tactical question, but I'm curious, for the mass campaign, does it include information about how hepatitis B is transmitted? And I think we touched on that briefly, but I'm curious to hear from you, Sarita, on that point.
Yeah, so a little bit, actually, not a lot. There's a little bit in our social media series that explains how it's transmitted. And with most of the campaign materials, it talks about not so much transmission through contact with blood, for example, or vertical transmission, but rather saying how people from certain countries may be more affected than others by hepatitis B, and just making people aware of that. And part of the reason we focused on this was the shift from the CDC guidelines to move towards universal screening vaccination. It previously was a recommendation around people who should get the vaccine if they exhibit certain like high risk behaviors or high risk conditions. And we wanted to spread the message that hepatitis B vaccination is for everyone. It's not just for people who, for example, use intravenous drugs or have unprotected sex, or, a number who have a mother who have hepatitis B, that got passed on during childbirth. It's really something that anyone can get, and it's something that everyone can prevent by getting their vaccine. And so we're more focused on that messaging than the exact means of transmission.
Thanks, Sarita. Yeah, that's really helpful to understand sort of why, why the messaging is created the way that it is. Another question for both of you. For both the campaign and the toolkit, could you share an example of how the cultural context of newcomer communities changed the way some of the information was presented? So, how was that cultural adaptation integrated into the assets themselves?
I can start. These are very specific examples, but for sub-Saharan African communities, we learned that Hep B sounded too much like HIV, reinforcing some of the stigma that is surrounding HIV and Hep B. So we recommended always saying hepatitis B virus in counseling in order for us to ensure that there's no mix-up, or that one, especially if one has more stigma than the other, and to encourage vaccination. And I think for Asian communities, family honor and collective decision making meant framing screening as an act of protection for the family, which also came up in the communications campaign, and that was more motivating than doing fear-based messaging or things to say, like Sarita said earlier. So these two insights kind of directed and shaped the scripts that we were writing in and the tips for providers within the cultural adaptation cards, or how we frame the facts in the establishing the facts cards.
Yeah, thank you. There's a couple different ways where you can see culture reflected in our campaign materials. One is the multiple formats. For example, having Rohingya available in audio visual, that's one example that I've mentioned previously. The whole idea about it being the Protect Your Family campaign and focusing on the idea of being able to stay healthy or stay strong so you can provide for your family, and really sort of leaning on that concept was central to the campaign. We're not talking about the whole greater community or your city or your state or even your neighborhood. We're talking about the people that are nearest and dearest to you, and that's some advice that we got from the community leaders. Another example is how we have very specific messaging around, the vaccine is not a cure, because we know that not everyone comes from a location where preventive healthcare is widely available. And some people may be used to only going to the doctor when they feel ill. And so when we're able to talk about, somebody might say, oh, well, I don't need the vaccine because I don't feel sick. It's like, well, the vaccine is to protect you before you feel sick. And also focusing on the nature of hepatitis B as being largely asymptomatic until your liver damage is severe. We have a picture that I showed in the beginning of the man with a soccer ball, and that's the one that people have looked at and said, oh, like a person can be a young guy who's playing soccer, who's like athletic and also have hepatitis B. It's like, yes, you don't have to feel very sick or look very sick in order to have it. And so those are some ways where we took the sort of the cultural context and incorporated it into the campaign in a way that you might not see in hepatitis B vaccine campaigns for a general American audience, for example.
Yeah, thank you both. I love the specificity of both of your examples. I think that's really helpful. And, it's not obvious, when you see the campaign, but I think it's really nice and very thoughtfully baked into the design. I have a question for Deanna. I'm curious, for the dialogue guide, you imagine that providers are maybe using them on their one-on-one visits. Do you have advice for people that maybe want to use it beyond a one-on-one visit, maybe in a community health class or outside of just a clinic visit?
Yeah, absolutely. And the Refugee Women's Network actually, who helped us with the time of the CHWs they run gatherings for mothers, and they're like, can we use, the guide? And I think it's absolutely possible, although it's intended or made for providers. There's no reason why this guide can be utilized along with a campaign to share information about hepatitis B with the mothers that join that gathering, for example, or place all the cards, on the floor or on a table and be able to pick them up and learn together what they are. It does not require a provider. Now, I can understand how the mindset section, for example, is something that's more catered toward providers, and you would want to follow up with vaccination and screening, but the beginning around the establishing the facts along with everything else that the campaign offers and the videos and everything, this can be shared together in a setting where they're sitting together and learning. And then I think as long as they're providing pathways to doctors or clinics in case someone shows that they'd like to get screened or vaccinated, then that's great, because that allows follow through and not just stays within that room. But that would be a recommendation.
That's great, Tiana. I think there's a follow-up in the chat. Would you recommend these cards for health fairs, community events? I think similar to that same question, all the different spaces.
Yeah, absolutely. And I think one of the providers even said, what if somebody wants to take the card with them? Because they sometimes, see people want to take materials, and there's no reason why not, right? Like it's not like it's going to harm. So definitely be a community events or health fairs. Why not? It just increases the awareness and knowledge around hepatitis B.
Great. I have one final question for both of you, maybe a fun one. What's one hope that you have for each of these tools? How do you hope people will use these materials?
So I hope that people will use these materials to advocate for hepatitis B vaccines. If anyone on this webinar has not gotten their hepatitis B vaccine, go out and get it right now. It's very important. So obviously, I hope people will use them in order to promote vaccine uptake and ultimately protect these communities from chronic hepatitis, from liver disease and liver cancer. But I think that I'm kind of proud about how it's, I think it could also be used as a proof of concept. Like, I hope somebody who, a public health person engaging with our campaign might learn more about which languages prefer oral versus written materials, or they could maybe use the conversation guide to learn more about their community's expectations or impressions or their knowledge around hepatitis B. Because, we worked with community leaders from a number of different countries, but they're by no means representative of all people in sub-Saharan Africa or Asia or even like newcomer communities, and really using them to start that conversation and learn more about your community is how I would hope that people would use the materials, and that would be the value I would hope that they would walk away from it.
I think one thing that I would hope for the provider toolkit or dialogue guide is for clinics or hospitals or healthcare provider settings to kind of look at it together. I don't want to use the word training because that's very formal, but go through it together, because we heard so much during our research about how important it would be to standardize the way every provider in the clinic talks about hepatitis B or counsels around it, or the methods that they use, so that it's all the same, and then the vaccination and screening rates would increase if everybody's doing it in the same way. And so I would hope that providers or clinic settings would bring it in, read it together, try it out with one another, and try to utilize it. So that's one way I heard from the providers, and I would hope that they might use it in that way as well.
Lovely. Well, thank you both so much for sharing all of these great materials. Thank you, everyone, for the questions and for your attention today. As we mentioned before, we'll be sending out the recording, the slides, and the links to everyone over email. And certainly be in touch if you are using any of these materials and want to share how you're using them. Awesome. Thank you, everyone.
All right, thanks everyone. Take care.
Thank you.